This is The Changed Physician, episode 219.
Hey, folks, welcome back to The Changed Physician. This is your host, Dr. Kevin Cuccaro, with my Amazeballs co-host, Dr. Melissa Katie. Dr. Katie, how are you today?
I'm great. We had a great interview, didn't we?
Yeah, it was awesome. And I guess this happens all the time, but it's like, man, there's so much we didn't talk about that we could have talked about. We probably could have talked for like 3 hours. You know, he didn't have the time, obviously, but so much to cover. So did you have any takeaways, or did you write anything down that?
Well, I'm just excited to go maybe meet him in Australia here soon.
All right. Well, I wrote some stuff down.
You can go ahead. I've got ideas, but go ahead.
Well, there was a couple, because there was the number one thing, and I think it's really important to understand, is that the evidence in medicine, or what a lot of things that we do in medicine commonly, simply don't have evidence that supports them. And the challenging thing, I think, from a physician standpoint, is when you start recognizing that something doesn't seem right, or if you're looking at the scientific evidence and you're saying, wait a second, even just anecdotally seeing things don't be seeming right, but everybody around you is doing them, that creates a very challenging environment to work in. And I do think there's a lot of physicians out there that question what we do, but because the system and their colleagues basically keep going forward and doing the same things every day, and they may be quietly questioning things themselves, but it's not openly discussed. You kind of almost think you're going crazy. Mm-hmm. And I know that was for me, that was my personal experience. And you're just like spine surgery data. You look at the spine surgery data and it's astounding that we're doing literally hundreds of billions of dollars worth of surgery, and the evidence is absolute garbage. Mm-hmm. But we have these massive spine centers doing this stuff. The knee arthroscopies is another big one for me. Like I at least, like, some of the stuff I remember in residency, you can tell me your experiences in residency too. Like, yeah. I remember being in the ortho room and you're doing these knee scopes, and I was like, this has got to be the stupidest thing I've ever seen, because they would bring people in, and then they would stick the camera in, and then they're looking around, and then they would basically go, and they'd kind of grind stuff around, grind, and then they would come out and it's like, oh, we're done. They didn't. I mean, and all I would be thinking is, wait a second, okay, so we're saying that the cartilage or the meniscus is the problem, but we know that the cartilage and the meniscus have really important not roles. Great. Yeah, they have important roles, and they don't have really good blood supply. So what we're going to do is we're going to go in and like cut them out it just literally didn't make any sense to me. And like, when you're watching the operation, you're not doing like anything other than grinding away stuff that probably shouldn't be ground away. And mm-hmm. and they do so many of these frickin' things.
Oh yeah.
And yeah, so that one was pretty, because I remember sitting in the OR just going, this is the dumbest thing ever, and I cannot believe people are having this done. And then so when the first study came out, and when he talked about that first study, that was a brilliant study, because it was when they actually put surgical incisions on those knees. And what we didn't talk about is when they did that, they did surgical incisions, then they had the patients randomized, one would get the arthroscopy, one did not, but they did surgical incisions on everybody. They anesthetized everybody. So which is astounding to me. And then they took them out, and then they ran them through the same post-op program. And in the paper, the people who didn't have the operation but thought that they had the operation actually did better than the people who it was not the same. They did better. The people who didn't get operated on. Mm-hmm. So, and yet, yeah, but you tell people this stuff and they're just like, oh yeah, but then, you run into somebody and they go get a knee arthroscopy for osteoarthritis or a meniscal tear.
I have to say something about that. So it's almost like when you compare them, the person that had the surgery and not functionally better, you think, did we harm them from their natural healing process too? Like, there's all these little questions that come up from that, not just this placebo, like, oh, well, both of them were helped for whatever reason, whatever. But I'm always thinking, oh, what's the harm? But when you said something about the procedure and like they just clean up and like rooter around and get all the little
cleanup is a bad word. We should say they grind the joint out, right?
Yeah, and they do all kinds of, like, they'll just suck up the little frayed areas. But the only thing that ever made sense to my brain is if they had a meniscus that was kind of like flipped on itself and couldn't free itself, and their knee was kind of like locked. That's the only thing that ever made sense to me. If it wouldn't unleash itself, that, okay, maybe you just need to flip it out so it's free to go, and it's at risk to do it again. But, you know, if it makes them functional again, that was the only thing that made sense to me.
Yeah, although the knees were never locked, like they were
No,
never
I know.
like
I'm
locked
just
in
saying
place.
that I'm just thinking of the
Catching.
rare, not catching like intermittently, but like literally like doubled up on itself and it can't move. Like that's the only explanation they could find. Like in my mind, that was the only thing that made sense to go in the joint like that to help free it up. But other than that, I mean, that's like one in how many? You know?
Well, and even then, it's like, what would happen if you just left it? Like it, so because it's flipped up in the operation doesn't necessarily mean it's flipped up all the time.
But what if their leg doesn't go straight? Like
well, that's what I'm saying is you'd have to, if someone can't extend their leg,
manipulate it or do anything,
manipulate it or whatever, then that's a different story. But most of these people can move their legs because these are elective procedures.
Right.
So even if we see it flipped up, and we don't know what's happening in vivo, like biologically in the knee. Right. And then the other part, and this is the danger of we do, and then we assume it's because we do that people get better. Mm-hmm. And we can just as easily say, in the face of lack of evidence, which we don't have, that people got better in spite of what you did, rather than because of what you did. But we don't ever want to say that. In fact, we don't even bring that in as a potential null hypothesis, right? And it happens over and over and over again. And it just is absolutely astounding to me. And this infuriates me. And I think I've said this multiple times throughout this podcast, like multiple episodes and multiple Saturday salutations, is if we as physicians, if you are practicing by anecdote and your anecdote is in contrary to the evidence, you are not a scientist anymore. And I love how he brought up, you know, these alternative whatever practices that are based on nonsense. Like when there's no evidence to support the therapy. In fact, there's a bunch of evidence that show it doesn't do what they say it does, and yet people still do it. And we as physicians like to poo-poo it and say, well, they're not practicing evidence-based medicine. If you're doing this stuff in absence to available evidence or contrary to available evidence, you're the same thing. Mm-hmm. You cannot make fun. I'm gonna pull out. You can't make fun of the chiropractors. You can't make fun of the homeopaths or anything, because you are basically doing the same thing. You're practicing voodoo medicine. And that one, and I kind of wish we named, like, if people heard, like, I don't have his first book, Surgery, the Placebo, so I'd be curious if you listed out the procedures in there. We know knee arthroscopies, shoulder arthroscopies, spinal fusions, lumbar laminectomies. We didn't even talk about the cardiac procedures.
OB-GYN.
Which one's an OB-GYN?
I don't want to say until I gotta double check.
Let me just on the cardiac one. So stenting, cardiac stents, where they put the stent in, people with stable angina who are not in the middle of an acute MI, and you see these people getting stents all the time, and then they put in, you know, and once you put a stent in there, you have a risk of actually developing an embolism again. That's why they have drug-eluting stents and all this stuff. My pet peeve, which I think the intraventricular cyst device, which is a big crock of crap that costs a lot of money, but they taught all the cardiology fellows to do it. And all you need for FDA approval on this stuff is literally evidence of non-inferiority, which they did. So you took a thing like intra-aortic balloon pump, which actually has a negative mortality associated with it. I'm using the word, we're probably wrong there, but basically they don't seem to improve survivability. In fact, they're associated with worse survivability when you put an intra-aortic balloon pump in. And I'm going to use the name because they decide to sue me because they have a lot of money invested in this stuff. But these left intraventricular cyst device were basically proven to be not inferior to a therapy that's already inferior, and so they got FDA approval on this thing. I'm what's the OB-GYN ones? I can think of a ton where you exploratory laparoscopies.
Well, I'm trying to see if I can find the operations. Actually, look, I have the book downstairs, and I should have brought it up here to demonstrate, but there was I don't want to say for sure, but like, I mean, that I know that just from experience, I've questioned the increased risk of C-sections based on convenience or
Oh yeah, that's a big one.
rushing this, whole Pitocin thing. I'm not in the field, but I do know that for centuries, our bodies have gotten a baby out when the body's ready in most circumstances. And so, I question on many occasions if this is really necessary. I mean, we're pushing the body to go faster and get it going, but it's not quite, in its mind, not ready. The body's not ready, in my opinion, without the evidence. But then sometimes the hysterectomies that are, I always, there's some reasons, obviously, if people are massive bleeding all the time and they can't control it and figure out hormonally how to control it. But I always was like, why are we rushing this person to have their baby right now? Like, and there's no medical indication other than they set a time or a date, and then it increases. I have to look at the evidence. Increased risk.
Well, and you're talking about in situations when there's no evidence of fetal distress. That's like the absolute key with all of this, is when there's no evidence of fetal distress.
Right. And you give Pitocin, oh, I'm sorry, the cramps probably hurt a lot more, than if you, I mean, they can be intense. And then, you're trying to cover that. And then there's a lot of pressure. And then and at some point it's like 16 hours later, like, oh, we got to go to C-section. It's like, well, maybe the body wasn't ready, for all of this yet. I don't know.
Well, and that's a tough one. I mean, that's
I know. That's why I'm not in the field, but I do believe that there are times where we probably push the envelope and create a surgery that's not necessary.
Oh, I think we did for all sorts of stuff. We do surgeries.
Yeah, but I mean, in that circumstance, I witnessed stuff that
I would say what's worse is the hysterectomies for abdominal pain.
Oh, hysterectomies, yeah.
Yeah, not hysteroscopies, but the actual hysterectomies, when they're like, oh, you know what, you have some endometriosis, and so that's going to be that's the quote unquote cause of all your pain, and we're going to take that out without looking at anything else, and then they do all these hysterectomies. Yeah. When we know that there are people who have endometriosis and no pain, right? Yeah. And when it comes to any surgery for pain, to me, should never be done. Yeah. Like, and when I was lecturing, what I would basically say is surgeries are performed not for pain. If people have alleviation of pain, that's always a secondary effect. But when a surgery is done not predominantly for pain, and this is what the overall data shows when you look at all this stuff from the arthroscopy, spinal fusion, all that stuff, that it's a total absolute crapshoot on whether or not people get better. And it is not necessarily the direct effects of surgery that are the primary factors that are there. Yeah. And so, like, and people, what do you mean when you have a broken leg, you wouldn't do surgery? It's got a painful broken leg. I'm like, well, you just kind of answered the question right there.
You broke
the leg is broken,
but it could heal. And it
could. But this is what is if, and this is like, if you're a surgeon, if you would do the surgery, whether or not there's pain, that's a surgery that probably needs to be done. Mm-hmm. Like if you have a fracture of your femur, and the person has no pain, no one in their right mind is going to say, don't operate or don't fixate that bone. Yeah. Because you're at severe risk of running around with this big old fracture, and you may get fat emboli, or it may lacerate an artery or a vein in there. Mm-hmm. So you always look if there was no pain, would I do the operation? And if you would do it. Like same thing with if someone has has evidence of a myocardial infarction, and they've got basically an occlusive thrombus in there, you're going to stent it, or you're going to plasty it, or you're going to recommend, definitive care on that. You're not going to just not do anything. But if you have nothing, or you see mild stenosis without significant lesion, like, 30% stenosis or something, putting a stent in there just because you're there is dumb. Or even worse, the people, and this doesn't happen as much here, but this happened overseas. It was a distal family member this had happened to, where they went in and they literally did like an angiogram. Then they said, oh, you've got stenosis. And then they took them back later to do the stent, like rather than doing it all at once because they wanted, I don't know. It's insane what gets done with this stuff. And yeah, so that was like the biggest takeaway. And I really feel like, man, we should just list out all the surgeries somewhere and put, make like a graph, because it's absolutely astounding. And these things are done every day. Thousands and thousands and thousands of these surgeries are done every day.
Yeah. Speaking of, just throwing a list out there and making a whole bunch of enemies that make money off of that. I found interesting the conversation is just reflecting in his awareness too of pushback and the reactions, especially off the second book, Hypocrisy or Hippocrasy, we said, is that he's a white, tall male who, oh, by the way, is an orthopedic surgeon. Oh, by the way, compared to other surgeons who aren't researchers, he's a researcher.
Mm-hmm.
So he has everything what maybe society deems as like
authoritative,
yes. Yeah. And yet Rochelle Bookbinder is short, rheumatologist, tons of accolades in the research world, but yet she's been getting, and a female, and she's been getting, a lot of flack from a lot of people. Just, I guess, a lot of hate in a way.
For decades.
But still, and what makes, deeper into this, what is it, the ethos of truth, I guess, and those people that are willing to deal with that kind of, being braided?
I part of it, and I'd have to look at Dr. Harris's, like what because I know he's published and he wrote a book and things, but the difference between him and Dr. Buckbinder has been involved heavily with guideline development and Cochrane reviews.
Mm-hmm.
And so he may be just saying, we're doing a lot of surgery, we shouldn't do it.
Yeah.
She's been saying, we were doing X, there's no evidence to support it, it shouldn't be done, which also then affects like insurance payments and things. So it's actually affecting it
universally.
It is saying this and promoting action to prevent the procedure from being done, and that's an effect on people's livelihood. If you're not doing anything to actively change this, like there's no actual threat. You could be spouting off on the curb all you want, and maybe people say, oh, that's good, and you're sitting there. You're not going to get as attacked as much as once you actually say this needs to be done. And then for her, who's a rheumatologist, then to be saying this against the surgeon, the surgeons get attacked. Like the surgeons who says we shouldn't be doing this, and they actually advocate for change in payment, I guarantee you they're getting attacked.
Yeah.
But for a non-surgeon to be saying it, they're going to get attacked more. And then, yeah, obviously, these perceptual biases that people don't think important. Being shorter has an element of you're viewed as less authoritative, which is kind of silly. Being a woman. Visual. Oftentimes is less authoritative than being a man.
Mm-hmm.
So I think that was a big one. And I do think maybe the other part of it is he may just not be, maybe not as aware of it, or maybe less personally involved. Because I also think you can get very, what's the word I'm looking for? Evangelical about this stuff,
mm-hmm.
where you become very passionate.
Yeah.
That's definitely me. Like it
me too.
And I don't necessarily think that's healthy though.
Yeah.
Because we're saying this, and we don't have any direct control on this stuff. We're not writing policy, we're not doing anything. And if you get very evangelical about it, and you're just like, and mentally, I think personally, I'm using a lot of personal examples here. You become more primed to seeing negative reaction. I get more upset when people don't listen,
mm-hmm.
Or believe the evidence that I'm talking about. Mm-hmm. I don't believe that's true. Well, I don't care what you believe. Look at the evidence, but don't say it's the evidence. That evidence isn't true. Well, then you need to actually do a study that counters that, rather than just saying your belief is anything else. So I didn't get that. I didn't get the impression from him he's as evangelical about it.
Yeah. Yeah. He also has kind of like I don't know, personality wise, just very kind of a calm, less threatening. So I don't know how the ideas and thoughts and passion are projected by Rochelle, but there might be a difference there too. But Yeah.
A
No,
couple other things, because I know we're trying to not keep this super long.
yeah.
One was the language use,
Mhm.
and the language use in medicine and how that impacts this stuff. Like we use so much language that sounds so pathological when we're describing normal age-related change.
Mhm.
You
Yeah.
know, disc degeneration in and of itself shouldn't, all the people here, and it's scary, but like the one I poked up was the big rotator cuff tear, when really we should talk about a degenerated or an age, the
Age-related.
rotator anatomy or the shoulder anatomy demonstrates age-related change would be
Yep.
much better than
Yes.
describing things as tears or blah, all these little scary language. Then
Yeah.
you and I know the effective language on
Oh,
how
yeah.
that impacts this people's perceptions, and particularly when it comes to pain. I thought that was a very, very big one. And I would like to see us in medicine being much more cognizant of the language that we use
Mhm.
when it comes to it. Like if you're seeing someone in your office, just recognizing that threats can be easily the language that you're using. The big one for me is, oh, your back is so bad I can't operate on it. That's the stupidest. Like, what are you trying to do with that? What you're basically saying is, I don't see anything focal that needs to be operated on.
Yeah. Yeah.
You have a bunch, of age-related change. You have a bunch of wrinkles in your spine, just like on your face. That we shouldn't be using this other things that we think we're trying to be compassionate, and we're just making, it's the sympathy digging the hole deeper and making it worse. Oh, I can't believe you're still working. Oh my God, you look so bad. I have patients that are half as bad and are on disability, but you're still, what the hell? That's such crap language.
I know.
And someone may come out feeling more satisfied, but they're definitely not going to do as well when they think that they're all broken and busted. So that was a big one.
Yeah. I feel like I should go back to my residency or fellowship in pain or residency in anesthesia or any of them. Just go back and do a little lecture on just the power of the words you use with your patients. That I'm like, it seems so silly, but I'm like, God, I think that's a perfect time to really like hone that skill when you're in clinical practice. Anyway.
Yeah.
What was your last thing?
Well, I have two other things.
Okay.
The other one was when we were talking about change in medicine and how evidence doesn't change practice, but really your environment and the social dynamic does. And I found that one really fascinating because it's true, right? We have all this evidence and all these procedures keep getting done. And I think he was talking about shoulder arthroscopies, despite the evidence showing that they don't do as well, actually increasing in the numbers. Maybe it's either because people aren't aware of the evidence behind it, or they just like to do them. I don't know. But we actually, this reminded me of something else. But to try to change the environment of medicine is extraordinarily difficult. And the only way that we can actually do that is we have to change the incentives. And that's where people get mad, because now we're talking about what we're going to pay for or we're not. And then then you get people all in angry. Oh, the insurance is denying it. And this is that. And who are they to say that I shouldn't be doing the surgery? Well, because you're not making your good decisions appropriately. If you're practicing voodoo, someone else is going to have to come in and say whether or not it's appropriate. So make good decisions.
Yeah.
But being the first person to kind of start that process, that's
Hard.
And without institutional, because there's nothing particularly in the U.S. health system, the U.S. health system is not incentivized at all to do the right thing. In fact, we're incentivized to do the wrong thing.
Yeah. Well, it's amazing how money and ego can keep sustaining the wrong things. So it's like you have to have these parameters and controls on that. But there's so much lash back from people when you start threatening it.
And that kind of leads into the other point that I thought I had never really thought about this before. We talked about the medical legal implications.
Mm-hmm.
And he said very specifically that, in medicine, what we are supposed to do that we don't is we're supposed to be evidence focused. Like, what does the evidence say? And if we don't have evidence, let's get evidence so we can be very scientifically minded about this stuff. But the legal profession is not evidence in scientific evidence. It's the weight of opinion. And that just made me like, holy crap, because that's so true. And so the whole, like, really the practice of law is based on opinion. Opinion is not fact. Opinion is not science. Opinion is not, testing a hypothesis to see what is true and what is not true. Opinion is just opinion.
Well, they're assuming the opinions based on evidence, but that's not always true because standard of care is not always evidence-based.
Well, and it makes it hard to create change. If all of your colleagues are doing the absolute wrong thing, that weight of a bunch of people doing crap is going to be weighed greater in a court of law than you following the evidence.
Yeah.
And I'm like, oh my God, that's true. That's going to happen because you get these quacks. You get these quacks even at an academic center spouting nonsense and I'm the blah, blah, blah chair of blah, 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 blah. And I believe we should be doing knee arthroscopies for osteoarthritis. And the other person comes up and says, well, I'm such and such. I'm in the community hospital and the evidence says this. And some judge and some whatever is going to take the freaking chair of whatever spouting nonsense over the person who's speaking the fact.
Yep.
That blew my mind because I hadn't really thought about that before. Like we always are hoping that science and fact and evidence supports change, but there's so many factors out there that are not consistent with at least what I would my ideal worldview, which apparently is totally flawed.
No, I feel like there's like your salmon going upstream trying to do the right thing. Like I don't think the fight should ever be given up, but I do feel like it is the systems in place are, I want to be optimistic, but unfortunately I'm not on this note, is that I feel like they're always going to be working against us. I don't know how you can take out the human element of all these factors of like their money and ego and the kind of people that might be drawn into the surgery field. Not all, but there's certain people that I don't know. I just even the way we're taught in training, it's like see one, do one, teach one. But this what you're seeing is not maybe evidence-based, but you keep doing one and teaching one, and it just keeps like perpetuating this standard that's not evidence, at least supported by some evidence, So I don't want to end on a pessimistic note, but I think there is some brilliant person needs to find a way to kind of break through these walls of the systems. And but it takes really brave people that are courageous enough to deal with the onslaught of anger towards people trying to do what's best for patients. But I did like the last two things that he had mentioned. You'd asked him like, what would you tell patients to say or do when they're trying to make decisions on like surgery, for instance, and how he said that obviously getting multiple opinions, see if they're contradicting each other, even though they all four could be doing a standard of care that's not evidence-based. That's always a possibility. But the other thing is, what are the possibilities of me getting better, or what are the outcomes if I don't do the surgery, and then what are the outcomes if I did do the surgery, and kind of an about face to see if the surgeon can answer that with at least not necessarily with perfect numbers, because that might be hard to dig up that, but a lot of times patients want that, but at least get an idea of if they say, well, you could get better on your own. If you give it 6 months to be patient, you might be better. I don't know. Like, I think that's reasonable, because like one of the things that always drives me nuts is like some of these, I won't go down this road too far, but basically like oh my gosh, I'm blanking on it. On your foot underneath, like, help me out here.
Plantar fasciitis?
Yes, plantar fasciitis. Just had a little brain moment there. But I've had that kind of pain. It's miserable. It takes time, it takes patience. I give it a lot of different sensory input, and 6-9 months later, it's better. But, like when I talk to podiatrists and, I'm like, so are people willing to wait? Like, no, most people are too impatient. They want something to be done like right now.
Are they giving the option?
Well, that's the question.
Yeah.
Like, I'm surprised that people think that something needs to be done. When I talk to friends or family, I'm like, well, give it time, but they're just they're just terrified of this like getting worse and da 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 da. And I'm like, well, you're not even given a chance. I mean,
well, and let's talk. That would be an interesting one to pull up the evidence on the surgeries for
oh yeah,
plantar fasciitis.
I've looked at some of it.
Yeah, it's not good.
No, and especially when you look at even at a microscopic level, what's really going on.
And again, what is that surgery for?
Well, there's
the primary indication for that surgery is.
Are you saying inflammation? Is that what you're saying?
Pain.
Oh, pain. Yeah. But
they
don't even find inflammatory cells when they do microscopic assessment.
That's what I'm saying is when the primary indication for the surgery is pain, that your warning flags need to go up. And when it's quote unquote plantar fasciitis, which again, fasciitis talks about inflammatory change, which isn't there. Right. They talk about bone spurs when there's all these people with bone spurs who have no pain. So we're now doing a surgery based on changes that are present in people without pain and saying that's quote unquote the cause of your pain. That's a problem. That surgery shouldn't be done unless there was really strong evidence to be done.
It should be more probably fasciosis, not itis. And anyway, you can go on and talk about variations.
But again, the primary reason they do it is quote pain. And that means crap, really. Yeah. And that part he talked about that. I can't remember if he did it in this because I was reading some of his other interviews before we actually went on, was the idea that a lot of times people are seen during a flare. And so they're recommended during surgery from a flare, like particularly when we have age-related changes in the body. Then there's now a flare of pain. And we know, and I think we've done an episode on this, that pain is constructed and there's all sorts of stuff going on. And then to go in and think that a surgery at that moment, when with an age-related, something that's age-related change associated, that is going to cure it, then probably you're going to be okay if you wait. That's like, I just, we don't have enough time in medicine. I mean, it's like I'll tell lay people is like, how do you know you need a surgery? Is when they say we need to go to operation right now. And if you're not going to take it right now, I want you to sign this form that says against medical advice.
Right.
If that's the case, you probably need that surgery.
But what's interesting, I normally say, unless it's life-threatening, problem is we talked about appendectomies and people would perceive that as maybe life-threatening potentially. So, the evidence that he talked about too is that, you could do antibiotics. Most people are fine. It's the pros and cons and risks and benefits of various things can lead to other problems down the road, anyway.
Oh, absolutely. So I have one last thing before we end, if you're okay with that.
Go ahead.
And that was when and this kind of ties in because you mentioned this is the second opinions. And in the absence of emergency, or even if there isn't, if you get somebody in the hospital, which you're not, but if you could, it sometimes is useful. A second opinion or a third opinion is great. But what I didn't say when he was saying it is a second opinion is supposed to be an opinion. What you are not looking for is an opinion that supports what you want. And what I mean by that, if you have a surgeon that says we shouldn't operate, trying to go to another surgeon who says you shouldn't have an operation. Another surgeon says you don't have an operation. Another surgeon says you don't have an operation. And then another surgeon says, oh, we can operate on that. You got to look at the whole of the opinions here.
Yeah.
And so people, see this all the time. They go doctor to doctor to doctor. This person didn't tell me what they want. This person didn't tell me what they want. This person didn't tell me what that. This person told me something and it feeds in my existing biases that I'm sick, I'm damaged, there's something wrong with me. So obviously this is the right doctor.
Yeah.
Could they be? Maybe.
Yeah.
But there better be a crap ton of evidence that supports them saying what they're saying. Because otherwise all you're doing is now, you're following where your biases want to go. And unfortunately, particularly in the surgical, anything that's incentivized there, you will find someone to do it.
Oh yeah.
In fact, if you find, seriously, if you go in and someone says, no operation, no operation, no operation, I don't care what the fourth, fifth, sixth, or seventh person says, don't do the operation because it's so hard to find someone who won't do an operation. If they're saying no, you probably really have to have a strong indication to counter that, the weight of those opinions. So kind of like if you're going in the opinion is nothing, like we should not intervene. To me, that's a much more forceful and weighted opinion. in the Cuccaro world, if we're looking at the medical legal advice of if we're weighting things on opinion as well as medical evidence, then someone says, oh, we could do that.
Yeah. Well, I don't want to bring up another topic because go off more and more. No, I really enjoyed the conversation. That could have gone a lot longer, like you said. But if there's anything that people can get out of this, if you're not a physician listening, is to have an awareness of just the things that, you know, Kevin was talking about, and know there's just not a lot of awareness of the bias and how we respond to medical professionals. And I think trying to kind of like step back and watch yourself and how you're reacting to these different opinions and what maybe your beliefs are, might be really helpful, at least in trying to make a decision. But if a surgeon who does surgery, by the way, being a little sarcastic there, tells you don't need surgery, you really should listen to that person, because that's counter to the money that would support his lifestyle. Doesn't build his ego in the sense of like, I'm doing the surgery and fixing them, if that's what their mindset is. And maybe just really cares about making a good decision and understands the risks and benefits of what you're asking for, maybe coming to him and wanting that, and you get shot down, that this is probably not the solution for you. Yeah, even if you may not have an answer on how to like deal with whatever you're dealing with. But anyway, those are my last thoughts there. But any last thoughts before I take us out?
Yeah, other than that, it's a great point. Like super wise words there. Because if you look at it from what is the incentive involved, and if someone's given you an opinion that is kind of contrary to what their incentives should be, that is definitely a high weight. Like, I love how you stated that. If you go to a surgeon who the incentives there, the best decision for them is to operate, and they are going against quote unquote their best interests to give you that opinion of not an operation, that is, yeah, that's a nice way to look at it. And now we're looking at it kind of an incentive way. Well, what's the incentive to do this? And in the absence of doing something contrary to what the incentivized behavior is, probably should make you think.
Yeah. Absolutely.
Love that, Melissa. Very nice.
Oh, well, thanks, Kevin, for the compliment today. Well, for those of you listening, if you don't know what the Change Physician is all about, you can go to thechangephysician.com and join the community, whether you're a physician or a physician ally. And we look forward to seeing you on the next episode. Take care.
Stay well, folks.